Hello and welcome to Oncology360. I'm Dr. Shamli Singhal. I'm the medical director of the cancer program, and today is my favorite day in the whole year. I appreciate so much that all of you have come. We are a big cancer family and so excited to see all of you and to honor our patients, our caregivers, our doctors, our healthcare providers, and all the people that support cancer patients. I would like to give, before too much time passes, if you have questions that are on your note cards, please pass them to the end of the row so that we can answer them during the panel, okay? And a big shout out to three people amongst a whole team of people that have worked very hard to bring this event to you. One of which, and I'd like to recognize our Chief Operating Officer, Tracy, who's here today, and she's over there, yes, and really appreciate that she came in today to celebrate with us. To Jasmine Jose, our Executive Director of the Cancer Program. She has been with us just a few months and made just a huge difference. You probably don't see all the things that she has made work, but she's there behind everything that goes on in our program. And to Linda Chuang, who's our outreach coordinator, and she has done a magical job of working with us today. So we have a full program, but what I wanted to start with is a little story about how we started, because many of you who have been here in the last bunch of years probably don't realize that this program is 20 years old this year. And so in 2005, the hospital and the hospital administrators wanted a new cancer program. They didn't have cancer services here, and everybody had to travel outside of the area for cancer services. The hospital, and particularly a woman named Ann Fife, who really had this vision that we should keep our patients with us in our community hospital. And so what they wanted us to do was to bring the services to the patients, not the patients to the services. And so that is something that we have held on to for all these years. And in 2005, I came here. We wrote the first set of business plans. We raised $10 million from the board, and we started building our first program, which was in the Melchorst Pavilion. Dr. Sinha, who's a radiation oncologist who many of you know, came in 2006, and Dr. Dormady came in 2007. We saw our first patient in December 28th of 2007, okay? We had one patient, one chart, one doctor, and one nurse. And now when you come to the Cancer Center, we're filled, we're overflowing. We have 6 new doctors, we have radiation oncologists, we have all the support. And so I feel like in the last 20 years, we have become a cancer family. Everybody in our program becomes part of our family. And we come together once a year, sometimes more times a year, but we support each other, we treat each other, we have respect for each other, and that's what we've built here in our community to keep our patients here with us. And so I thank you all for coming this morning, and what we will do right now is something that's so important to us, and I'm going to introduce Elise Swanson. She is going to come and give the cancer survivor recognition. All right, and so really appreciate her time this morning, and to recognize all the people that have been part of our community. Please come.
Thank you, Dr. Singhal. My name is Reverend Elise Swanson. I'm an ordained clergy in the United Methodist Church and a chaplain here at El Camino Hospital. Outside of the hospital, I also work as a community psychotherapist, providing pastoral and equine-assisted psychotherapy. As I introduce myself, I think it would be really wonderful if we could just take a brief moment for you to turn to your neighbors and introduce one another to yourself, so that we know our neighbors. Please take a moment to do that. I hate interrupting this. I look And I see such amazing connections going on here, and it's just beautiful. And those in charge, including Linda, have told me I have 10 minutes. So I'd like to just take a moment to acknowledge and honor all of you here today. And I'd like to maybe just invite you to think, for those fighting the good fight right now, who are in their process, I'd like you to raise your hand, if you can. How about those celebrating their first anniversary of being cancer-free? Come. Second or third year? Okay. 5 years? Yeah. Okay. How about those who have survived more than 2 or more diagnoses? Yeah. Okay. I think it's just so important for us all to be able to turn around and see one another and the places and the journeys that we've been on. So to know that we're not alone in that. June is Cancer Survivor Month. It's a time to recognize you and more than 18 million others who are cancer survivors. And it's also here to acknowledge the work done to improve the lives of survivors and their caregivers. And speaking of that, I'd like to invite those here today, too, that are care providers for those that have related to parents or partners of cancer survivors. I don't know if there's anyone here that are wonderful. Thank you. Later, we're going to hear from an amazing group of panelists as they respond to some really great questions around cancer detection, survival, and more. However, I'd like to take a moment to name, too, how one's cancer journey goes beyond the organs and tissues that make up our body to impact us psychologically and spiritually. Not long ago, I came across a poem that beautifully expressed that experience. And I've got it up here on the board, but let me read it. The storm raged, a chaotic dance, a tempestuous, cruel expanse. It clawed at the soul, a relentless fight, leaving shadows of endless night. But through the darkness a flicker grew, a resilience strong, shining true. The winds may howl, the rain may fall, but a survivor stands, defying all. The scars remain a whispered trace of battles fought in this forsaken space. Yet from the wreckage, new life takes hold, a story of courage bravely told. For a survivor is not defined by the storm, but by the strength that keeps them warm. They rise from the ashes, reborn, renewed. A testament to what was endured, with each sunrise a hopeful start, a fragile bloom with a wounded heart. The whispers of wind, a gentle guide, as a survivor walks with nothing to hide. They rise from the ashes, reborn and renewed. That line strikes me. Dare I add resurrection to new life? The tree of life epitomizes this growth and renewal. The cancer journey is most certainly a transformative experience. Or it can be. And for those who've been touched in that way, you are not simply a survivor, but a thriver. Maya Angelou said, "My mission in life is not merely to survive, but to thrive. And to do so with passion, compassion, some humor, and some style." May each of you, no matter where you are in your journey, meet this moment not only with the badge of surviving the last and greeting the next moment, but also by thriving and celebrating each precious moment with nothing to hide. And with that, may I just say, Happy Cancer Thriver Month. And in that, I would just like to close by offering this prayer. Dear God, we thank you for the incredible strength and resilience of those on their cancer survivorship journey here today. No matter where they might be in that journey, we celebrate their perseverance and their continued passage toward healing. We pray for continued strength, passion, and self-compassion as they navigate each step along their path towards wellness. May they be surrounded by your loving presence as it is manifested through family, friends, care providers, and even the stranger that crosses their path. And may they experience renewed hope and joy at each step. We thank you. We thank you for the miracle of survival. And we ask for your healing touch to continue to work within them always and forever. Amen. Thank you.
You got it. Thank you so much. Really appreciate your wise words. So we are fortunate to have a patient's story. And so I'd like to introduce to you Honora. Honora is one of my patients and one of Dr. Dormity's patients, but Dr. Dormity is going to come up here and share the stage with you, and we welcome you to the stage. Please come. Yay! And we have your flowers with you. Okay,
Thank
come,
you.
Dr. Dormity. Yep.
And I'll put this here. Okay. All righty. Oh, you wore the cape.
Created by you.
Hello.
So I can
Hello.
see it.
Thank you so much. Okay. And I am so happy to be at this event and happy to literally still be on the planet. So my name is Honora, and like some of you in this room, you heard those 3 words, "You've got cancer," and it turned your world upside down, and it was so scary. The first time I heard it was actually 10 years ago. And my son Jameson was turning 6. My daughter was turning 3. It was my very first mammogram. And there were 2 spots. It was stage 0 very early. They said maybe a lumpectomy and radiation. But I didn't want to be worried the rest of my life. So I opted for the double mastectomy. And it went well. And my friends took me to Hooters, and we celebrated the fact that I would have the perkiest set at the old folks' home. So I didn't look back. I didn't think about it. I moved on. Fast forward to 10 years this past year, I had COVID, and there was some lumpiness and soreness under my armpit, and I felt a little tiny bump, and I didn't even think anything of it. a couple months went by, and I felt that the lump was bigger. So I went and got a mammogram ultrasound, and they ended up doing biopsies. My insurance had switched, so I had to switch doctors. And I looked at a lot of different doctors, and I cyberstalked Dr. Smiley Single. Dr. Single had this amazing philosophy of mind-body connection, and she was so confident and calming. And so I made an appointment with her. And I saw her actually the day before kindergarten started. So I was in my classroom getting ready. I went over to see her, and she told me the news that not only was the tumor growing and it was cancerous, but it had also spread to my lymph nodes. So the next week was a blur of just medical appointments and teaching. I was so overwhelmed. It was really rough. I was so busy that I had to schedule my nervous breakdown for that weekend when I could just sob and cry and wallow and feel sorry for myself. I also did a lot of comfort eating, crazy bread from Little Caesars, raw cookie dough. I noticed that if you drink a bunch of the little bottles of Prosecco, it doesn't feel like you're having a whole bottle by yourself. And then I moved on from the wallowing and the depression to the anger phase, which was I was bitter and I was mad. I was literally laying in an MRI thinking about all the people I wish had cancer instead of me. So I know I'm a kindergarten teacher, but I got pretty dark. And then I decided enough. I needed to flip the script. Cancer wants you to feel out of control, and I needed to take control. So the first thing was assembling my rock star team. So I had the amazing social service workers of Camino and Hope, and they handled all the paperwork of medical leave and the advanced care directive. They handled all of the paperwork. It was awesome. Nutritionist Nicole, she counseled me on what to eat to keep my strength up and be healthy through the process. I mean, she's not going to convince me to run on purpose or like choose salad instead of fries, but she really did try. And then we also had Nurse Denise. She was amazing. She handled all of my side effects and all my medications. And she told me something that no medical professional has ever said, and that was, we don't want you to lose weight. I was like, challenge accepted. Not only did I not lose weight, I gained 23 pounds, and I still have them today as a souvenir. So that's really nice. And then, most importantly, dun dun dun, I met the man, the myth, the legend, the GOAT, Dr. Dormady. There he is. He's incredible. So I met with him, and he told me that my cancer was called HER2 triple positive. He told me how aggressive and serious it was, and that he wanted me to be involved in a three-war attack against cancer. So it was going to be chemo, surgery, and radiation. It was terrifying, but he had such confidence, and he said, I have a plan. We've got this. And I did the biggest nesty plunge trust fall into this man and his plan and the people at El Camino, and I really trusted it. And that's why I gave him the cape. Oh, he said, by the way, we're not just going to stop the cells, we're going to disintegrate them. And that's when I named him Dr. Disintegration. That's his superhero name. So I assembled the medical team, and then at the home front, I had my counselor and I had my Reiki practitioner. She would do Reiki before, and she would even bless the medicine going into me. I had my acupuncturist that I saw before every chemo session, and she gave me a bunch of supplements to take. The parents at my school were amazing. They set up a meal train, so 3 times a week we were getting home-cooked meals, which my kids had never had before, so it was actually really, really great. My friends took care of me. We went out we got manicure and pedicures, and I got a facial. I got my teeth cleaned. I set up a chemo cart with all my stuff that I needed. I even got my eyebrows microbladed because I'm very vain like that. My Italian Catholic mother sitting right there, she also dragged me to church to get the anointing of the sick. So we were ready to roll. So we started with chemo. I had 6 rounds, and yes, I wore my Hooters shirt to the first chemo. After the first round, where my mom stared at me like a newborn she just brought home from the hospital, I started having friends take shifts with me, and my friend Holly called it the chemo cabana, and we tried to make it fun. We had People Magazine and Netflix, and we would bring snacks and drinks, and my very last chemo was December 23rd. It was my early Christmas present. And I got to ring the bell and earn my bear. And we all did shots of apple cider in the hospital, and it was magical. So that was probably the hardest part, was getting through chemo and managing all the symptoms. My acupuncturist and my Reiki person and my counselor really helped. So one of the hardest parts of chemo is losing your hair. Every time my hair was falling out, it was traumatizing to me. And so I decided to take control again. And I called my hairdresser, and we went in, and before she shaved it off, I said, let's have a little fun. We did a mohawk and a man bun and a comb over and a troll doll. And I took control of that situation. And Dr. Dormady liked my shirt. My oncologist does my hair. My friend with alopecia gave me a bunch of her old wigs, so she taught me how to take care of my wigs. And I bought a couple at Next Step on National Avenue. And then I used the hair that I had lost to fashion toupees for my dog Sunshine, the first ever dog toupees coming to fine pet retailers near you. Next step was surgery. This was really simple. It was Dr. Single. She's amazing. And we also partnered up with Dr. Lee, the plastic surgeon. I had to put that poster in. The posters at the doctors and the plastic surgeon is so funny. And the surgery went really well. I was disappointed when I woke up and I didn't get the Brazilian butt lift and full body lipo that I asked for, but they did a great job. And of course, because I wanted to understand all of El Camino, I developed a seroma and had to go back to the emergency room with my mom, and they had to open me back up and clean it up, but it was fine. It went really well. The last phase of my attack was radiation, and I had the pleasure of being across the street with Dr. Shumway, and sometimes I would see Dr. Mehta. My friends call them McDreamy and McSteamy. They're so handsome. So the team over there is amazing. They are so wonderful. They're supportive, and they're so comforting. They even put warm towels around you when you come out of the locker room, and Dr. Shumway took so much time explaining the whole process. I mean, when you're young, your mom's like, don't stand in front of the microwave. And then here I am laying on this machine for 10 minutes. It was very scary. But they were like a well-oiled machine. They were like the Jiffy Lube of radiation. They got me in and out of there. They even have a really good coffee machine, so every day I could make a latte at the end. And so I did 25 sessions of radiation, and it went really well. I'm so thankful. And throughout the process, I tried to use humor to get through it. So I do some recreation for my friends and family. I'm Dr. Evil and Mr. Clean, and there's Britney Spears having her breakdown. So I like to use humor throughout the process, and it really helped me get through the hard times. Apparently, I had too much time to myself. Anyway, let's see. So lastly, throughout this whole journey, I said I would eat it, drink it, smoke it, sacrifice it, whatever got me healthy, I was going to try it. I said yes to everything. So naps and lunch with retired teachers and walking the beach and taking my son to concerts. And I tried Tai Chi and Qigong. I went whale watching. I went kayaking. We just went yesterday again. I love it. Equine therapy. I had tons of supplements that I took. Sound bowl healing. I did so many different things. If you're going to be sick in California. Like, it's so awesome. Going out to the beach, going into the redwood trees, and just feeling connected to the earth. It was a beautiful place to heal and recover. I'm trying to be quick. I know. Okay, so thank you. Alrighty. So basically, cancer for me this time around was the vehicle I needed to really transform myself and to really start to learn how to ask for help, accept help, how to have boundaries with others, and how to check in with my own self and what did I need, and that self-care wasn't selfish. I really learned how to do all of that. Having boundaries with people, cutting toxic people and things out of my life, and knowing going forward, I'm not willing to get cancer in my body again for anything or anyone. So I love that survivors, we now get to come out of this, and it's like life is in HD, right? Your 5 senses are more alive than they've ever been. So whether it's the smell of my daughter baking cookies, or the taste of a hot chai latte when I'm at a coffee shop with my friend, or seeing the ocean and the clouds and how magical and beautiful it is, petting my dog, or feeling someone who loves me hug me, and hearing my kids say, I love you, Mom. With my teenage boy, it's like, love you. Anyway, I am so happy to still be here and still be alive and be like the good chaplain said, to be thriving now. I have a new sense. My story is not over, and I get to write the second half. I'm so happy. And I have my friends and my family and the parents and the teachers and the kids at my school. And I really have all of these beautiful doctors and nurses and staff. El Camino Hospital, I never felt alone. Everybody would be like, why are you not a puddle of tears on the ground? And it was because they all lifted me up so much. So I just want to thank you guys so much from the bottom of my heart. And I'm so happy, and I love you guys so much forever. So come give me a hug. I need a hug.
Yeah, no, stay here. Stay here with me.
Are we going to do it?
Yeah.
Our duet? Islands in the Stream?
Yeah, that's right. We tried to plan this out, but I know we don't have a ton of time, but I would be remiss not to say a few words here about both Honora and everyone here. I mean, as Dr. Single pointed out, I've been here since the inception of the program, and, you know, it's funny. I see people out in the hall today and patients I've taken care of and these miraculous outcomes we've had, and you start to get a real sense that you become family. I mean, you become family to me, and I've become family to you. When you go through these incredibly intense life experiences together, it's like, how could we not become bonded? So, you know, your will to live, your strength, your resiliency, it inspires me to keep doing my best to help everyone. And, you know, but you're all warriors, and God bless all of you to keep this fight going. And I'll be there with you every step of the way as long as I can keep fighting. This is my life's passion and work, and I love taking care of all of you. It's an honor and a pleasure given to me by God. But I will tell you, once in a while, you bump into a rare patient. You bump into a patient who's such a character that you know, it brings out the best in you as a physician and a person. You know, I'm a comic book fanatic, and I love superheroes. And so the cape this was created by Honora, so I'm wearing it in her honor today. And when it says Dr. D on the back, that works because, of course, Dormady. But she told you the true story. I could tell. You know, Honora wanted to just trust the plan, and I had to tell her, we're not just going to beat the cancer cells. We are going to disintegrate them. They're going to evaporate. And she liked that. So next thing I knew, I had a cape, a custom-made cape. So, but really, Honora, your story is as funny as everything you've ever done and said. I think we'd all agree that elementary school teachers are special angels that deserve special attention, and it's been my honor to take care of you. And I think Honora didn't emphasize one thing, which I wanted to emphasize medically, which is when we did all of her treatment, we actually did the chemotherapy and medications to target the cancer like a guided missile. We did that before the surgery, and at the time of surgery then, Honora's results were miraculous. There were no cancer cells
Yeah, my tumor
remaining.
was gone.
It had evaporated completely. That's called a pathologic complete remission. And a person...
I've been called pathological before.
Yeah, you lived up to your namesake, that's right. But anyway, again, God bless all of you. God bless Honora and her miraculous story, and let's keep doing great things together for the next 20 years at El Camino.
Yes, yes. Love you.
Yeah, I love you.
Love you. Ooh. All right.
All right. Thank you so much, Honora, and so appreciate hearing your story. I've known you for all these months, and having it all put together is magical. All right. So next, we are going to have the physician panel. And so I'm going to ask the doctors to come to the stage, please. It's Dr. Dormady, Dr. Ho, Dr. Jayachandran, Dr. Rajasekar, and Dr. Shumway, and Dr. Taylor. So while they're getting their microphones on, I would remind you to do your note cards if you're interested in asking questions. And then if you would do that, and I will move myself to the side. It's my great pleasure to introduce my colleagues to you. They are all part of our big team. And actually, because we have now grown, they are not all of the team. They're only a subsection of the team. So Dr. Shumway is on the end, radiation oncology. Dr. Catherine Taylor next to him is psychiatry. And Dr. Rajasekar, medical oncology. Dr. Ho is a breast surgical oncologist. Dr. Jayachandran, medical oncology. Dr. Dormady, medical oncology. I'm Dr. Single. I'm a surgical oncologist, general for everything. So I thought what we would do today is a little bit of fun in the beginning. And so I'm going to say something about one of these doctors, and they will recognize it about themselves. Okay? So, who was a candy striper in this very hospital when she was in high school? Mm-hmm.
I'm definitely. Yeah. Yep.
Okay, Dr. Jayachandran for that one. Okay, and so who rides his bike to work every day?
Yeah.
Dr. Shumway.
It shows.
Who, despite being a superhero, likes to sing and does karaoke?
Oh, crap.
Who is the best one at karaoke?
After Honora's mini bottles of Prosecco, maybe.
Okay, and who out of this group actually likes doing laundry? I know it's not Dr. D. Centers me. Okay, and who gets up at 1 o'clock in the morning to watch soccer for a team that loses all the time?
Not soccer, it's football. You actually kick the ball.
1 o'clock in the morning, I want you to know. So now you know a little bit about them as humans in addition to doctors, all right? And so I'm going to ask them a series of questions, and they're going to chime in with their best answers to some of these things, okay? So I'm going to start with Dr. Dormady. What do you tell your patients about lifestyle choices? What do you tell them when they get diagnosed?
Well, I tell them, it's not just a lifestyle, it's kind of a mentality. I think Honora's story exemplifies that the best. To defeat cancer and get a leg up on the situation, you have to have your mind, your body, your faith, your spirit all aligned and moving in the same direction. So it's kind of a life philosophy when you get the disease. And I try to tell every patient, I tell everyone, please remember, you may have cancer, but cancer doesn't have you. So, let's just do the best we can together. Sometimes you will catch a cancer at an earlier stage and you're treating with curative intent. But even if you don't, I tell patients in this day and age, don't worry. We're not worried about this is stage 4 or this and that. The page has turned in oncology. I tell patients you have a medical condition. Just understand it that way, just like high blood pressure or diabetes. And we can use incredible molecular profiling of the cancer cells and put together the right medicines to keep the disease stable indefinitely in many cases, and just like high blood pressure and diabetes. But in terms of pure lifestyle, my nurses and NPs, and they hear me say this 1,000 times a week, I always teach patients too. And in addition to comic books, I was a big fan of professional wrestling. So I loved Hulk Hogan. And, he would always, instead of saying the 3 commandments, he'd always misspeak and call them his 3 demandments. So I tell the patients, your 3 demandments are you have to hydrate, you have to stay active and exercise as we fight through this together, and you have to keep your calories going. And I try to tell patients, when you're under active therapy, try not to be too restrictive with your diet. Just keep the calories going, and we can't have you lose weight. You need your calories to fight the disease. And then, after the heavier treatments are over, we shift to more of a cancer-healthy diet. But that's my general philosophy.
Okay, so I want to ask Dr. Taylor, okay? Dr. Taylor has two sides to her story, one of which is that she's a psychiatrist, okay? And so she talks to patients about all the things that everyone struggles with. But she herself was a patient. And so I'd like her to tell a little bit of what that was like as the two sides of yourself.
I think that's a really important thing to talk about because, especially as a physician, we get used to treating other people's issues. It's nice to be able to kind of compartmentalize and say, I'm going to address somebody else's problem. And when you suddenly wake up or you go, for me, it was the second mammogram ever. And it's been now 11 and a half years. But it was such an experience because I just don't think about it happening to you and what you need to do. But it's been a good process for me to go through that. And also, as I realize when I'm talking to patients as well, I'm also thinking about all the experiences that I've had and how it might help me to understand what people are going through. I can't use my experiences to determine what it's going to be like for someone else, but I can experience that. I can feel the emotions. I can live through it. And for me, I think the biggest thing was really the anxiety and the fear. And then I'm used to getting up and thinking, what do I want to do with my day? And getting up and having that fear and saying, well, but am I sprinting to the finish line? Am I getting my treatments done? But then you get your treatments done. I was in remission. I was told everything was going to be great. And then you realize, wait a minute, I have to do this. The race is still going on. Like I feel like I'm there and I'm done. The doctor said I'm done, but I don't feel like I'm done. This is, what do I do with all the anxiety that's inside? Or what do I do? How do I take that next step? And I think it's actually taken a lot of time. I had my, 11 and a half year follow-up last month. And he finally said to me, we can come every year. And that was, I think, the first time. It took 11 years for me to say, yay, after the momentary, oh my God, waiting a year and realize, wait a minute, I can do this. This is something I wake up every day and want to say, what do I want to do with my life? It's like you go on vacation and before you come back, you plan or you fantasize about the next trip. So kind of for me, it's always been looking at it and saying, why do I want to be alive? The fear of dying or the fear of having to go through this pain or this anxiety, remind myself, what is it that I want? And how can I focus on that? How can I even just with the keynote speaker that in a sense, the trip, the battle, the cancer, the race, that doesn't have to define you, but maybe the goal can define you or the happiness or the joy. Or for me, it's, crocheting little things in the middle of the night. What is it that brings you that joy? So I think recognizing that you're human, that the anxiety is there, that those emotions are there, but it doesn't necessarily mean that there's a reason in that moment to change your life because of that fear. That anxiety is there, defines who you are, and then move on to the next thing and figure out what you're going to do to bring that joy back in. So for me, I think it's really been having to recognize those two parts and try to combine them, and that it's okay to be anxious, and that doesn't have to define me today. I can just get up and go, but to recognize that it's still there and it's okay.
So I realized that I forgot Catherine Taylor's, I talked about everybody else's little things, but what you don't know about Catherine Taylor is that she's a big fan of Halloween. And so she has a party at Halloween that is planned for many months, and the Halloween decorations stay up for a whole year till the next time. till the next time. But I want to tell actually a story about Catherine Taylor, which I will ask Dr. Shumway the question, okay? So when Dr. Taylor finished her last radiation treatment, it finished at 9:30, okay? And at 10:30, she found herself at the airport going to Hawaii because that's what you do when you finish radiation. And so I have a question for you, Dr. Shumway. What do you tell your patients about travel? What do you say to them about should they travel an hour after radiation finishes?
Honestly, the biggest barrier to travel during radiation is that I don't want patients missing radiation appointments.
Yeah.
But yeah, there's no restrictions, generally speaking, on travel during or even right immediately after radiation. I think one thing most people in this room probably know, but a lot of people don't understand is when you're getting radiation, the radiation beam is on and then immediately it turns off. There's no more radiation in the air and there's no more radiation in you. You're not radioactive in any way. So in that regard, travel is completely safe and completely fine. Obviously, Some patients will have different side effects from radiation. So depending on the side effects that they have or that I expect that they might have, I might counsel them differently with regards to that and traveling, in that setting. Yeah.
Dr. Magisaker, what do you tell your patients about travel?
I would echo Dr. Shamway's thoughts on travel during and after chemotherapy. I ask the patient to be extra careful with hydration, exposure to people who have infections. I would stay away just because you're on chemo, you're immunosuppressed potentially. So you don't want to catch an infection that could, cause complications that could, impair or change outcomes. Besides that, I would ask patients to stay hydrated, especially with long distance travel. That's risk of blood clots and cancer, which are at high risk of blood clots. Those are the general keys I would advise patients on.
So do you want people, so chemotherapy starts on Tuesday. Do I take my vacation now or do I take it in the middle? When do I take my vacation?
I think
Do I
the
have to wait till
answer. I think the answer depends on the type of chemotherapy you get. If it's something that's cytotoxic, meaning it's going to bring down your blood counts, it's going to immunosuppress you, I would probably not take a vacation where you're going to be exposed to big crowds of people. Certain other treatments, they don't suppress your immune system a whole lot. So, going out because you got a monthly injection to keep your bones healthy, that shouldn't change your plans for vacation or going on trips. I would encourage patients to ask me if they are planning on going on trips, because I can give them an educated opinion on what would be the right thing to do for that patient in that particular setting.
So I have a whole drawer of cards and postcards and pictures from God knows where that they went in my office, and it's a testament to the celebratory nature of when treatment finishes. Okay, and what I have two tips. I have two pro tips about that. Take your medications. Take a list of what it is that has happened to you in case you end up like my one patient ended up bicycling in the south of Spain and ended up in a hospital in the south of Spain. And so they called me in the middle of the night asking me what to do about her. And so I would say, just take your paperwork with you would be my pro tip on that. And so I'm going to ask Dr. Ho.
One of the thought is just that, I think patients should also understand, though, if you do have to travel, on one hand, we're telling patients, live your life, put the cancer on the back burner, fight, and kind of, don't let the cancer rule your mentality. Like I said before, you have cancer, it doesn't have you. So sometimes there are things that are immutable. There's a wedding or a family emergency. So, rest assured, there are ways to minimize your risk of infection if you have to travel too, whether it's white blood cell booster shots, wearing your mask, meticulous, fanatical hand sanitization. So, I would also present the idea that it's not necessarily dangerous to travel if you have to either. And sometimes you can take day trips safely or little vacations while you're on treatment, and that breaks up the monotony of the appointments and the blood draws and so forth. So it can be helpful too.
So Dr. Ho, when does survivorship start? So we surgeons and medical oncologists, radiation oncologists have a disagreement about this. So when does it actually start?
Yeah, this is a really good question. And, other patients have stopped by and asked this, but survivorship starts at the moment of diagnosis. We are surviving and we are fighting every single day. And so survivorship is a very important concept, as we move patients through treatment and then also life after treatment too. And this is something that we definitely want to focus on because we hold our patients so close during treatment. And then after treatment, there's almost a sense of, oh my goodness, I'm kind of being dropped off in terms of, appointments and follow-ups and everything too. Survivorship is so unique and we have to address so many needs that come with survivorship too. The treatment, the side effects, everything that comes with it too. We talk about the connection of the mind, body, and spirit. We talk about functional recovery too. All of those things are very, very important in survivorship through treatments and then after treatment too. So I say overall that the moment that we're diagnosed, that is when survivorship starts.
Okay, so there was a big splash this last couple of weekends ago at ASCO about the role of exercise. And so I'm going to ask Dr. Dietitian to comment on that study and exercise as a whole, because, many of us are in the fitness protection program. So what is it that we have to do?
Yeah, so exercise is very important. Obviously, it's something that's easier said than done for many of us, myself included. But it is imperative. It's so important for cardiovascular health, for maintaining a healthy weight, for basically every part of the human body. Exercise has a beneficial role. And that's really what we've been learning over decades of research and looking into these things. As far as cancer itself, we're now learning more and more about the role of exercise and nutrition. So we know that certain cancers can be linked to obesity and lower physical activity levels. I specialize in breast cancer. Breast cancer, for example, is often dependent on estrogen levels in the body. It can be estrogen receptor positive, meaning that the cancer cells essentially are feeding off of the estrogen that's floating around in our bloodstream. And obesity, excess body fat, can actually lead to higher levels of estrogen in the body. So that may be part of the reason that we're seeing more women with breast cancer, more women at younger ages developing breast cancer. There's also a number of complex things that are playing a role in that we only partially understand. There may be environmental risk factors, in addition to weight, people having children at later age affects hormone levels. There's a lot of things in our society, our environment that are playing into that. And we only are touching the surface of that in terms of our understanding. Recently, there's been more research on looking into outcomes with colon cancer and the benefits of exercise in that regard. And it's really all very promising. So I think exercise plays a big role in terms of prevention. And it also plays a big role in terms of getting through treatment. So, as Dr. Dormady was saying, treatment, going through chemo, that's not the time that we want you to go on a crash diet and, lose a bunch of weight. That's not what we're saying at all. But exercise can also help you get through chemotherapy. It helps with energy levels. It helps with a lot of the fatigue that's associated with our endocrine therapy. So it really improves your experience, your quality of life when you're going through treatment. And we're also learning more about diet in this regard. We're learning more about fasting, mimicking diets, maintaining low blood sugar levels in the normal range. All of that contributes to a healthy environment in the body where your own immune system can work better with the treatments that we're giving you and work better to fight off the cancer.
Great. So the actual recommendation that came out is 150 minutes a week with twice a week strength training, twice a week flexibility. Now, what I heard from the people that were talking about this is that that's either an aspirational goal or it's a starting point. And one of our medical oncologists, Dr. Lee, instructs her patients with this, which I think is kind of a great suggestion. She said, you go for a walk, you park your car far from Costco and walk to Costco, do a lap around Costco before you shop, but wear a backpack. And in that backpack, put a couple of cans, put a couple of bottles of water so that you're actually have some weight extra. And so she tells all of her patients this, and it's kind of a low-level suggestion, right? You're going to go for a walk, take the bottles of water in a backpack. So there's some low-level things that you can do, and the amount of improvement comes at about 7 to 10 minutes. So if there's New England Journal of Medicine articles about yoga, about Tai Chi, about meditation, about all of these things. Now, and we're not trying to force everybody into an exercise program. But if the last study that came out has a 38% improvement in survival, it's now medicine, right? It's not just an option. And so we're trying to incorporate that more in how we talk to patients, that there's a balance. There's things that doctors do for you. We give you medicine, we give you tests, we give you all these things. But then there's places where patients participate so that together we have better outcomes, right? So this is one of those things. And
and absolutely. And that's where patients have so much control and so much power too. It's not just the physician coming and saying, here's a prescription, here's pills that I want you to take, here's an infusion that you have to show up for. We're really working together as a team, and there are things that I can provide and counsel you on and medications that I can recommend. But there's also things that you can do in your day-to-day life to help strengthen your body, help strengthen your mind in dealing with all of this. and really improve your experience, your ability to tolerate the treatment, and have a better outcome. Right. And so there's 3 categories of people, right? People who exercise before they ever got this disease. Then there's the people who have disabilities of sorts, like you have heart disease, you have neuropathy, you have bone mets or whatever. Those are people where a specialized exercise program is important. And so there has to be an assessment and then a structure that goes along with it, because we don't wish you to be injured. We don't. And the simplest exercise is walking, and we're all for that. And although I will say that for my patients that ask me if I park far from Costco, I don't, because I'm always late. And so if you're going to do that process, then you have to build in some time for that.
Yeah, the Costco thing's a little dubious, Sarah. You know, I park far away and walk, but then you go in and you get the hot dog. It backfires on me every time.
Yeah, exactly.
Yeah, I think patients should understand too that I think mechanistically, you might think, why would exercise have that big an impact on survival? I think, just to put out the theory, I think a lot of people theorize that regular exercise stimulates the activity of your immune system, and that there's a constant tug of war and battle between your immune system and the cancer cells as to who's going to win. So the exercise really gives your immune system some support, like the cavalry is coming in to help attack the cancer. I think that's where a lot of the benefit lies in terms of the outcome statistics.
Right. And so one of the lecturers said something which I thought was interesting as well. It says, make your body hostile to cancer cells. Right. So what's that going to take? Right. That idea that you are building up your immune system to do this process. Okay. So I'm going to ask Dr. Shumway, what is the best thing that's come out in radiation oncology this year?
Oh, there's a lot of things. So I'd say one of them is we have some new indications in prostate cancer. So indications using targeted radiation therapy. One word for this is SBRT, stands for stereotactic body radiotherapy. And then another type of radiation that's a radioisotope that's infused into the bloodstream, and that can target metastatic prostate cancer cells. And so we did actually have a kind of new FDA approval that greatly expands the population of patients with metastatic prostate cancer that this therapy is available for them. That's just one example in one type of cancer. Things are constantly evolving, as you know.
Yeah.
But yeah, keep your eye on things, because the radiation is changing all the time.
Excellent. Okay, Dr. Taylor, can you give us 3 tips to deal with fear of recurrence?
I think the first one, actually, I used to see on my way to work. There's a local junior high, and they had a statement up on the billboard, and it said, remember that you have gotten through 100% of your hardest, worst days. And I think it's just to remember that you have. Yeah. You have gotten through a lot of things before, and you can do this too. And so I think having that hope and that feeling that you can be struggling, but you can do it, and believe in yourself, and don't let at least the fear that you can't. So I would say that would be having the hope and knowing that you can do it. And then find some joy. I often tell patients to find something frivolous to do. My specialty is really in treatment-resistant depression. And a lot of times you see people who are feeling hopeless and helpless. They've tried at least 3 or 4 medications, maybe other modalities, and being able to really get to that place where, okay, what are we going to do next? So I think being able to just take it that next step.
Okay, I'm going to ask Dr. Dormady this one. Do I still need to see my primary care doctor when I have an oncologist? Why do I need to see primary care?
That's funny. That's a funny question, because our social worker, Kimmy, is here, and it drives her crazy, because I tell patients, when you're going through the treatment, in large part, the oncologist kind of becomes your primary care physician. I mean, if you're seeing your primary care physician maybe every 6 months or once a year, you're seeing us, once a week sometimes multiple times per week. And, all of us are board certified in internal medicine. So, when little things, digestive problems, acid reflux, high blood pressure spikes from some of our medications, bone density issues, we have to kind of jump in And I always felt it's sort of your job as a medical oncologist to take care of the problems you create. So some of the primary care doctors, I've tried to explain, we're not trying to step on your toes, but if I'm giving a medication that makes a woman's lipid panel escalate or her bone density suffer while we're trying to treat her breast cancer, that kind of falls within your purview to fix the problem. But I think it depends on the patient a little bit. It depends on the doctor. I mean, there's a point where you get so saturated with doctor's appointments and blood draws and so forth, having yet another one with your primary care doctor can be a little bit much depending on what you're going through, and your oncologist will pinch it. But generally speaking, I think it's a good idea to, at least from time to time, see your primary care doctor, even if you're seeing us once a week, just so they kind of stay abreast of the process and know what's going on with you. And once in a while, no doctor can think of everything. And sometimes I've had patients go to their primary care doctor and really kind of help manage a problem really effectively with me. And just, hey, if it's in the name of a better outcome for you, our patients, absolutely. The more the merrier. The more doctors, the merrier.
Right. And as we succeed in our cancer treatments, people actually do get other diseases. Right. So the primary care doctors are helpful in all of that. Okay. So, Dr. Ho, what is functional recovery? What does that mean?
Yeah. So whenever we talk about treatment, we talk about side effects, we talk about fatigue, we talk about what the treatments do to our body, whether it's from a surgical standpoint, after surgery, an axillary lymph node surgery, a breast surgery, or even from a medication standpoint, whether it's endocrine therapy or chemotherapy. And functional recovery really encompasses recovery from those side effects. And it's really important to address these things. Whenever we're going through treatment, we're going through the steps, putting one foot in front of the other, going through treatment, getting through this, getting to the next step. And then afterwards, there are side effects that come from the treatments, and we have to address that. We have to sit, we have to talk about that. And I think that there are things that we can address better. There are a lot of sexual side effects, for example, from the medications that we give to patients. We talk about libido, we talk about vaginal dryness on the breast side, as we give endocrine therapy. And then from the surgeries that I do myself. So numbness of the breast, swelling of the breast, lymphedema, swelling of the arm, numbness underneath the armpit. And so that's when we incorporate physical therapy. We incorporate a lymphedema therapist too. And it really all goes back to the holistic care of the patient. Really intersection of the mind, the body, and the spirit. We really want to take care of you from a physical standpoint, kick the cancer, make sure that it doesn't come back. But the mental health part is extremely important too. The spiritual part is extremely important too. So this is the functional recovery that we talk about. All of this is very important in the journey for our patients.
So we want you to get back to your regularly scheduled life and get back to it in a way that has good quality of life, right? That's where we're talking about. So I have a question for Dr. Shalway. What is proton beam, and does it work better?
Yeah, proton beam therapy is actually a type of radiation therapy that's been around for quite a while. It differs from photon beam therapy, which is the type of radiation that the majority of people will get and need for cancer, in that you need a much larger, much more expensive machine to deliver it. It's actually, in terms of a particle, it's a much heavier particle than a photon, which is massless. I don't want to get into the deep physics, but proton beam therapy does have a role in oncology. That role, however, it's still pretty limited. And so you'll only really find proton beam therapy available at larger academic centers, and really only in a few spots in the country. Currently here in California, I think the only place is down in Southern California. I think in the next 3 to 5 years, there will be a proton machine developed at one of the universities here in the Bay Area that will be available. But generally speaking, most cancers are not going to need proton therapy. Furthermore, there have been some big trials, one that was presented at our big meeting last year in prostate cancer, looking at treating prostate cancer with proton beam therapy. And is there a difference in efficacy or toxicity compared to just traditional radiation therapy? And that was a negative trial. There was no difference in either efficacy or toxicity. For the most part, there's going to be some limited head and neck and brain cancers and pediatric cancers that really would benefit from proton beam therapy. And I've had a handful of patients where I do strongly feel like proton beam therapy would be helpful, and I send them to the academic center for that.
Yeah, excellent. All right, Dr. Rajasekar, our newest tool in the armamentarium is immunotherapy. And can you tell us a little bit about how that works?
I'll start off with Dr. Shane's comment about exercise being important for stimulating your immune system. There's this concept of immune surveillance in the body, where your immune system not only attacks any external bacteria or viruses that gets into your body, but there is an important role for the immune system to identify abnormal cells our body produces all the time and root it out. That is called immune surveillance within the body. What was found is in some patients with certain cancers, primarily kidney cancer and melanoma, they found that if these patients started developing sepsis when they have a bad infection, the cancer sort of disappeared magically. Like people are like, why the heck does the cancer go away when you get sepsis? Like there's nothing that makes sense. And then what they found was if you stimulate sepsis-like conditions in patients, sometimes the cancer goes away. And they started finding out why this is the case. And there's a lot of chemicals that we call interleukins that basically stimulate your body's immune system and makes the immune cells recognize the cancer cells and kill them. There's several ways we achieve that. The old school way was creating sepsis by giving the patient chemicals that stimulate the sepsis-like response. The problem was there's a lot of mortality associated with that. They're creating sepsis, you know. But there are more controlled ways we're able to do this now. So these drugs called checkpoint inhibitors, the big one that's been used more often is a drug called Keytruda or pembrolizumab. And what it does is basically makes your immune cells recognize the cancer cells and kill them. Cancer has this force field around it that sort of shields it from immune surveillance. This Keytruda or drugs of that ilk, like nivolumab and other drugs, they basically remove that force field so that the immune cells can recognize the cancer and kill them. Unfortunately, it doesn't work in everyone. There are some patients where this works. So, just like we're in Silicon Valley, so I guess I'll use a Silicon Valley analogy. Every year you get a new iPhone. Need that new iPhone? Not really. But every 4 or 5 years, there'll be a big step up. This was a big step up, say, 10 years ago, and we're finding more niches where it might be useful. This is typically effective in about 10 to 20% of patients, but in some cancers like kidney, melanoma, it's extremely effective in a majority of patients. Now, the third iteration of this is called CAR T-cell therapy, or chimeric antigen receptor therapy. This is science fiction. I am a big science fiction fan. So you basically take a patient's immune cells, rearrange the DNA so that it exposes a receptor that will find the cancer cell and kill it. It's called CAR T therapy, and it's very effective in certain lymphomas, certain pediatric leukemias, certain adult leukemias. And you asked John about new advances. So there's this even newer advancement in CAR T therapy. The problem with CAR Ts is it causes sepsis again. It attacks your brain, causes you to get confusion, lots of side effects. But there's newer variants of this CAR T where you inject the CAR T cells into your body and you sort of focus ultrasounds onto tumors, and the CAR T just goes into that area where you put the ultrasound, turns on, and kills the cancer cells, and if we remove the ultrasound, the CAR T switches off. It is literally science fiction what they do. And this is very early in development. They're doing mouse models and maybe some canine models where it's been effective. But it's fascinating to me. And I think there's so much that's going to happen. And you talked about ASCO, finally, I will say. The big focus now is also on how do we turn what's called cold tumors, where immune system responses are not very effective, to hot tumors. How can we flip the switch so every patient can respond to immunotherapy? And there are some mechanisms that are being identified. I think in the next 5 to 10 years, we will hopefully get there, and a majority of patients might be able to get benefit from these.
Excellent. That's cool.
Yeah, there's one other variant too.
Yes.
There's these immunotherapies are starting to ping pong off of one another and be sandwiched together. As Dr. Rajasekar just said, probably the breakthrough class of medicines were these PD-L1 checkpoint inhibitors that remove the cloak on the cancer cells so the immune system can recognize them. But in that setting, the immune system sort of unstimulated. It just has better recognizability for the cancer. There are other immunotherapies that can actually supercharge the immune system as well, making the immune system heightened and more active. And those two classes of medicines are sometimes put together. And in addition to the CAR T, there are also many of my patients have enrolled in clinical trials where they get a personal vaccination created from their tumor cells. And so how interesting is that? Speaking of, science fiction, where, it creates an immune response, a vaccine to police your body for your personal cancer cells forevermore. So that's kind of a hot area as well. And then some protocols give the vaccine in addition to some of the infusional immunotherapies to heighten the response to the vaccine even more. So this is one other piece, the vaccine.
So I'm going to ask the panelists about these liquid biopsies. Where do liquid biopsies fit in all of this? Priya, you want to start there?
Yeah. So the concept of a liquid biopsy is essentially that we're trying to get the same information that we have traditionally gotten from literally putting a needle into a tumor and extracting cells. So that's how we diagnose cancer in the first place. And as many people in this room have experienced personally, we see something on a scan, we identify a tumor, and then we put a needle in and we take some cells out and we look at them under the microscope. And that's how we say, okay, this is a diagnosis of breast cancer, this is a diagnosis of colon cancer, whatever the case may be. Well, that was kind of the first step. And then over the years, we've learned that, hey, we can stain a colon cancer or a breast cancer. We can stain these cells and look for different markers. And we can target our treatment a little bit more specifically that way. And that's been kind of the mode of our practice for a number of decades. Now we're able to look even deeper into these cancer cells. We're able to do molecular profiling, where we look at the gene expression within the cancer cells and better understand the behavior of a specific cancer and target our treatment even more specifically. So with a liquid biopsy, we are trying to avoid the invasive procedure that's involved in putting a needle in and going through that. That can be painful. Depending on the location in the body, there can be complications associated with it. So obviously, it's a lot less invasive to go to the lab and get your blood drawn. What we can do now is identify what we call circulating cancer cells, circulating tumor cells in the bloodstream. We can also identify circulating tumor DNA. So even when those cells break down in the bloodstream, their DNA is kind of released. And we are able to use that information for a lot of different things. We can run those same types of molecular tests that we run on a tissue specimen. So we can look for specific markers to figure out if a cancer is going to respond to that immunotherapy that we were just talking about or not. We can also use that for surveillance and monitoring response to treatment. So for example, if somebody has an advanced cancer and we're starting out on treatment, we may be able to do this type of liquid biopsy up front and not just identify that the cancer cells are there, but quantify how much are there. And then we start on a treatment, and maybe a few months go by, and traditionally we would be relying on repeating a scan to figure out how well the treatment is working. Well, now maybe we do that blood test, and we say, hey, those circulating tumor DNA, the level has gone down. That's a sign that the treatment is working, and we keep going. Sometimes we can even get that to an undetectable level. On the flip side, maybe the treatment is not working so well, and we're seeing some levels come up. So we can use this for monitoring our response to treatment. We're also learning more and more about how to use that in diagnosis and early detection of cancer. So
finding that somebody has a cancer even well before we can see it on a scan. So these are all very promising things, and it really all falls under this realm of trying to do better personalized medicine. You know, kind of gone are the days where we said, you have this type of cancer, this is the one-size-fits-all treatment. We now realize that there are subtypes within each type of cancer that respond to different treatments, and we're now learning that, gosh, just like every single person in this room has a different DNA makeup, every cancer can have a different DNA makeup. And so giving the one-size-fits-all treatment really doesn't make sense. And we're learning more and more how to better target those treatments and have better outcomes.
Dr. Dormady, you give chemotherapy before, sometimes you give it after. How do you choose whether to give it before or after?
Well, just one thought about the liquid biopsies and solid biopsies, molecular profiling. You know, just like Dr. Jayachandran just said, gone are the days of the carpet bombing of chemo. I think the key thing to also note is as we find these molecular alterations in the cancer cells and we get more personalized, the treatments that target these mutations you find often have, you know, triple, quadruple, 10 times the efficacy of standard drugs with usually greatly minimized toxicity. So that's really the name of the game, right? Better therapy while maintaining quality of life and fewer side effects. But in terms of, so chemotherapy before or after surgery, a kind of a general principle is if the cancer is more advanced, let's say it's just acquiring the ability to move into local lymph nodes or drainage centers in the area. We call that locally advanced cancer. And you can see that in breast cancer, head and neck cancer, colon and rectal cancer. There are advantages, in my opinion, to giving systemic treatment before you do your local treatment on the primary tumor. You know, some advantages are, you know, remember, the cells that are dangerous to you and threaten your life are really not the tumor cells you see in the primary tumor. It's the invisible little seeds, the little micrometastases floating through your bloodstream. Those are the cells that can set up shop in other organs of the body and, you know, cause life-threatening problems. So when you give chemotherapy before surgery, you start to attack those little seeds faster. You know, and there are some situations where we've seen if you do the surgery first, God forbid, there's a complication with the surgery and your son now delayed 2, 3, 4 months down the road, and you haven't even begun your attack on the cells that are most dangerous. So I think in many different forms of cancer, the paradigm is shifting to use chemotherapy and systemic treatment before your local intervention. But sometimes if you catch the cancer by accident, sometimes as an incidental finding and it's really small and you've caught it early, sometimes just going directly after the primary tumor is the better thing to do. So,
yeah, so we haven't talked much about surgery. Dr. Ho and I are surgeons. And so what we are hoping for is that early detection makes it easier to find cancers, easier to treat all of that. And so early detection, I think every one of us panelists would be all for early detection. Now, the early detection rate, people who get their mammograms, people who get their colonoscopies, people who get their prostate surveillance or endometrial surveillance are in the 10 to 15% range. Like the surveillance rates are very low. And the other part that we haven't talked about today, we've talked about it in other panels before, is about family history. So if you know about your family and looking at your family, are you someone who's at risk for developing malignancy? And if you are at risk for developing that malignancy, then you should know about it. You should know your screening. You should get on with your screening. And I have suggested this in the past, is that Thanksgiving is a great time to find out about your family history. So before you sit and you eat, go through your family tree and find out who's got what. And then you can engage in this family history thing. So Dr. Ho, can you please talk a little bit about genetic testing in your panel of patients?
Yeah. You know, I think it's so important just because we talk about all of these things that we do to treat patients, but truly as oncologists, prevention is the key, right? And so we really have to shift the focus on that because prevention leads to everything else that's downstream as well. And we have modifiable and non-modifiable factors. You know, we can't necessarily control our personal or our family history, but we can have a little bit more awareness about it. So what Dr. Single is saying, understanding your family history, understanding who has been diagnosed with which cancer, at what age, that can be very important too. For breast cancer, understanding family or relatives with male breast cancers, that's extremely important. And then that puts us on a pathway for stratifying risk for a patient. And risk is important. It's important to know our numbers. It's important to know our risk because then it allows us to be proactive in the future about that. And so one of the ways that we learn about risk is sometimes testing our DNA just to see whether or not we carry a gene that puts us at risk for breast, ovarian, pancreatic cancer. And so we have these different panels that we can use to test for these genes. And that allows us information to be proactive. It goes into high-risk screening too. We can talk about screening patients at a different frequency, different types of screening too, especially for the breast. For the breast, we know that we recommend annual screening for average risk women starting at the age of 40. But maybe for women who are at high risk, who have a genetic mutation, for example, we start screening earlier. And then we add on additional screening too, like breast MRIs. And so that knowledge gives us power. I think that's one piece, the genetic testing piece. But all of the information that we ask when patients come in and we get a history, your personal history about menses, how many pregnancies you've had, if you've breastfed, all of that feeds into a risk assessment for women, and it gives us a number. It tells us if a woman is at average risk for breast cancer or at increased risk for breast cancer. And that number also allows us to be put on a pathway where we can talk about prevention, being proactive, whether that's screening or medications, for example, that Dr. Jayachandran can prescribe to reduce a woman's risk for breast cancer, or we talk about the lifestyle factors too. You know, I really think that we underestimate the importance of exercise and diet. It is so important. And we are getting more and more data about this, which is supporting the things that we can do. But, you know, we also talked about, you know, being able to regain control, right? And that is something that patients can do to regain control. You know, changing the diet, increasing our exercise too. And it's not that all this has to be done at once. It's about small steps, integrating more activity. So I talk about, you know, taking the stairs sometimes, or, you know, adding on fruits and vegetables. We talk about eating the colors of the rainbow. All of these together reduce our risk for cancers in general. And so I think genetic testing provides, you know, a certain piece for us, but then also the history that you provide for us and the history that you gain from learning from your family, and your personal, you know, close relatives about this will give us a risk assessment for patients.
Okay, so she did briefly tell you about these lifestyle choices, right? And the lifestyle choices lead into a new program that we have here at El Camino, which is starting in the summer. So stay tuned about that. So we strongly feel that these modifications to your lifestyle and encouragement about lifestyle features. And so the lifestyle features are starting with exercise, because we've talked endlessly about exercise. But there's sleep, there's stress levels, there's food is medicine, things like, I'm blanking on the other two. But anyway, so living in community. So there are these 6 lifestyle issues, and we've added 2 more. So we've added fatigue and fear of recurrence to that list. And what we're planning to do is we are going to engage the services of health coaches, right? And so patients will have access to these health coaches and be not assigned, but you can choose a health coach to help you be accountable to some of these things that would help you be healthier as a patient. And the reason that we do this is that the benefit of exercise, we've talked about 38% improvement in survival, but there's numbers of other trials which have documented survival in myeloma, survival in breast cancer, recurrence rates, improved quality of life. The list is just getting longer and longer and longer. So we've engaged this kind of unique way of working with patients so that the health coaches will be with you as part of a support system to you to help you to do the things that will help yourselves. And so that is a program that's coming up. The health coaches, some of them are here, they're around the corner, and you can certainly talk to them. So I have a series of questions. If anybody has more questions, I'm open to it. So some of the questions are a little bit on the particular side, but I'm going to let Dr. Dormady take this one. Does El Camino Cancer Center provide all services for cancer patients?
Essentially, yes. I mean, we're very proud of that. In fact, I mean, we have, of course, your doctor. Each doctor has a nurse navigator that helps patients navigate the process, get all of their tests and procedures scheduled, referrals to other doctors, and so forth. We have our clinic nurses who field calls from patients pretty much around the clock, answering immediately, usually within an hour when patients have problems or concerns. We have our nurse practitioners that help us see patients independently. And if patients are sort of getting sick and need extra attention between their appointments with their primary oncologist, we have our nurse practitioners to help. We have a wonderful social work team that helps our patients deal with short and long-term disability, letters. Sometimes patients will have relatives overseas, and we need to write letters to embassies and consulates to get their family members here to help them battle their cancer. We have an oncology certified psychologist who's wonderful, Dr. Nishida, who, I haven't had a patient see her yet who didn't rave about her, and she's wonderful. She really focuses on patients' battle plan, their emotional and mental battle plan to kind of attack the cancer and stay in the game. And, we have palliative care services in the hospital. We're working on transitioning them into the outpatient setting and kind of formally implementing an acupuncture program. So, and we have our dietitians as well. So, oncology certified dietitians who are wonderful, and you'll be hearing from Nicole later. So, I think we do have a comprehensive program, and we're very proud of it.
So I'm going to speak to the surgery side of things. The surgery side of things, we have robots, we have spyglass, we have operating rooms, we have new surgeons that specialize in various things, Dr. Ho being one of them, who's breast surgical oncologist. I'm a general surgical oncologist. We are able to do majority things at this hospital that most academic medical centers do on the surgical side. And part of what we're trying to do on the surgical side is we're trying to do things more minimally invasive, right? We're trying to do them so there's fewer days in the hospital, fewer recovery days. And that whole experience is much easier for us when the cancer is earlier. So the more prevention you have, the more we are able to detect them earlier, the easier it is for us to do these things minimally invasive and get you back again to your regularly scheduled life. Dr. Ho can speak for a minute about cosmetics and doing cosmetically appropriate surgery.
Yeah. It used to be, whenever I talk to residents and fellows about the trajectory of breast surgeries, we used to do maximally invasive surgery. And so patients would come with these radical mastectomies. They would have their breasts, their skin, and even the muscle removed too. Patients would come in and you could see the outline of their ribs, but that is no longer the case. So now we have patients who qualify who can get lumpectomies. So lumpectomies where we just remove the cancer with a clean rim of tissue around it, and we preserve the breast. And there's opportunity to do something called oncoplastics as well, or we involve the plastic surgeon, and they reconstruct the breast. They lift the breast so that women have a good cosmetic outcome. And this is important to us because, of course, we want to treat the cancer. We want to keep it from coming back. But people are living longer and longer after the diagnosis of cancer because we have such great medical treatments. And so cosmesis is so important to us too. We want to get rid of the cancer. We also want to make it look good as well. There are also opportunities to preserve the breast too, and the cosmesis in mastectomies. We have techniques called nipple sparing mastectomies, where we preserve the skin, the nipple, and the areola too for patients that qualify. And patients have a very, very good cosmetic outcome from this.
Okay, Dr. Taylor, we have a whole slew of things about patients' mental health. So maybe you can comment we have just a couple of minutes, but I think it's so important.
I want to focus on a new program that we have because our cancer center recognizes that the mental health component, that the psychological component is extremely important. And the El Camino Hospital Foundation has put together a grant to help start a new program for breast cancer. We're starting it here, where anyone in the community, whether or not you're getting your cancer care here, because we feel that we are community-based, is we have an association with Concern, which is an EAP, an employee assistance program, to be able to provide up to 5 free sessions with a psychologist to help you in your individual cancer program. There should be some flyers out here to be able to know that there can be some support for that. So I feel like we're really expanding into that, understanding that it's a comprehensive approach.
And I think that's so important to remember. And, when you're going through the fear of getting a cancer diagnosis, knowing that you have a team available that's all ready to work together, ready to work hard and fight on your side in this battle is so important. There's a lot of things that we're talking about in terms of lifestyle, things that you can do, change in terms of modifying your risk for cancer. I think it's also still important to remember that sometimes people do everything right and then they still wind up with cancer. And so that's a question that I commonly get asked. Well, doc, I didn't smoke, I didn't drink, I ate everything I was supposed to eat, I didn't go to McDonald's, and now I have breast cancer. What the hell, right? So I think it's really easy to start trying to blame yourself, and that's not the right thing to do. It is not your fault. There's things that we're starting to understand more and more about genes and how they play a role. We're learning more about the environment and how that plays a role. But we're all really on the same team in fighting this fight. It's not your fault if you end up in this position. Obviously, it's happening to everyone. It's happening all around us. Kind of going to the point of the sci-fi comments, we're talking about genes, and that's, something that we've always thought we could never change. Well, now there's something called CRISPR. We actually are able to change genes and cure diseases. So it's all very exciting, and hopefully one day cancer will just be a thing of the past.
It won't take Sally Tuesday, but I think one thing to just to let everyone know, I with Dr. Single and our dear friend Dr. Sinha have been here since the inception. I want to tell everyone here, the panel before you right now, and our current team of medical oncologists and the surgeons, the team the people we've added, this is the best team and most dynamic team of doctors that El Camino's cancer program has ever had. And I'm very proud of them. It's great to see the program blossom like this, but you'll never meet a more dedicated group of people. The difference between us, we are the People's Cancer Center. Make no mistake about that. You're never a number here. And I'll guarantee you that every doctor on this panel, from Dr. Single to Dr. Shumway, and everyone in between, is pathologically accessible to their patients. And, you're not getting the medical student, you're not getting the resident, you're never getting the fellow. You're getting your doctor all the time here, pretty much 24/7. So we're all very passionate and dedicated in battling your cancer with you.
Well, I appreciate the panel, and I would say to you all that Dr. Giro is at the Ask the Doctor table. Dr. Lai is at the Ask the Doctor table. We have 4 more radiation oncologists, and we have a whole bunch more surgeons that are also part of this team that may or may not be here today, but you will always have a chance to meet with them. So I thank you all for your thoughtful answers. I thank you all for all your extraordinary hobbies of Comic-Con and soccer and everything else. I have a bunch of questions that were here, and some of them I couldn't answer because they're very specific to people, and some of them have been answered by the panelists. And if you would like, we will leave the questions at the Ask the Doctor, and you can ask your specific questions there. So thank you so much for coming and for this. And I would like to introduce, I would let the doctors go, and they will be at the various Ask a Doctor places all a day. And be sure and get your picture taken with them. There's they are available for photo opportunities as well. And so I'd like to introduce our nutritionist, Nicole, and she's going to talk about intuitive eating.
All right. So my name is Nicole. I'm the Oncology Dietitian. I met several of you over at my booth. I'm I'm going to try to make sure I address both sides of the room. I'm going to be talking about intuitive eating today. So has anyone heard of intuitive eating? Just raise your hand if you've heard of it. Okay, great. Has anyone ever read the book, or do you know there's a book about intuitive eating? Okay, excellent. All right, so today is called Intuitive Eating 101 because this is a relatively short presentation. We're going over the basics, but now you know that a book does exist if you ever wanted to get that. I'm going to be asking a few questions during the presentation, and then there will be time for questions for me when the presentation is over. Okay? All right. So these are some descriptions about intuitive eating. So it's using your intuition, your own inner knowing, rather than external factors to make your decisions about food. Also, this is a focus on well-being instead of dieting or food restriction. So dieting is has very much been at the forefront for a long time, and intuitive eating is an anti-diet approach. It's about having a healthy relationship with food and knowing that you are the expert of your own body. Nobody knows your body better than you do. There's a technical term called interoception. Has anyone ever heard this term? So this is the understanding of your body's internal senses. So this is a direct experience. Examples of this are hunger and fullness, your pulse, maybe just feeling your heartbeat, a need to urinate. So these are all things that we experience daily. These are things that are happening inside your body. There's another term called interoceptive awareness, also known as body awareness. So this is also paying attention to those sensations. So knowing what's going on and paying attention to those things. So I was talking about external factors, and we are exposed to these all the time. So these are things that influence our decisions about eating. So maybe people only eat at a certain time of the day, and they're very rigid about that. Maybe they only eat a certain amount. Maybe they're very confused about what should I eat? There's so many choices. Maybe they, convenience items are just so easy to get, but they're not the healthiest. There are supplements, there are weight loss drugs, there are all these things out there that are kind of in our peripheral at all times. So as we talk about intuitive eating, I hope you leave here today with a change in perspective. I hope you have an open mind because a lot of people, some people have heard of intuitive eating, but a lot haven't. So keep an open mind and as we walk through the different steps. Okay, so first question for the audience. I'm giving you 3 choices. Okay? Milk chocolate, dark chocolate, and a tangerine. And if you visited my table, you saw I had chocolate on the table. So think to yourself for a second, which of these are you going to choose? Dark? Everyone's saying dark chocolate. Is it because I'm up here? Is that why? The dietitian wants me to choose dark chocolate. Okay, so let's talk a little bit more about what thoughts came up for you. What thoughts came up about these 3 decisions? Kind of what was the initial thing that you thought of that caused your choice? Sugar? Okay. Flavor? Pleasure? Yes, we're going to be talking about that. Yes. Okay, good. Yeah, more and more research about dark chocolate and the benefits of dark chocolate. So wonderful. Okay, so think about what were the factors that went into your decision. Was it the fear of judgment? I have to choose the healthiest option, or were you wanting to be a rebel and you were thinking, I'm going to choose, the opposite of that? Were you really following your cravings? Maybe there are religious or cultural factors. Maybe there are food allergies. Does anyone else want to talk about something else for them that came up when they, like something that influenced their decision? Yes. So someone said over here eating for pleasure, and then you're talking about anticipation. Yes. I was talking about the book. There is a book called Intuitive Eating. There are two authors. There are two dietitians. The names are there on the cover. And this was actually first published in 1995. So this concept is 30 years old. I was exposed to the third edition of the book, the one there that was published in 2012. There has since been a new edition, the fourth edition in 2020. And you can see there on the cover in very big letters, it says anti-diet approach. So that's what this is about. Also, it's about making peace with food, freeing yourself from chronic dieting, and then rediscovering the pleasure, someone over here said that, of eating. And just a little disclaimer, I have no connection to these dietitians. I don't benefit from their book sales, okay? Just letting you know. So this is an example of, I do feel like there's been somewhat of a shift in the media when it comes to talking about dieting. So this first magazine cover is from 2014, and there are lots of words. There are lots of words about diet, and it's very much at the forefront. And then in 2017, there's another cover, and it's more talking about body confidence. So you can see there was like more of a shift in body positivity, body confidence. And then 2023, there's a magazine cover there, very few words, and it's focused on the woman on the cover. So this is, I do feel like there's been a shift away from that kind of mindset. So maybe the trends have changed, but the mentality maybe hasn't, because dieting and food restriction has been so at the forefront for a long time. And so the mentality is hard to break. Intuitive eating is evidence-based. It's been looked at in over 125 research studies. As I mentioned, it's an anti-diet approach. It's an approach that helps avoid yo-yo dieting. So that's losing weight and losing and gaining, which is actually worse for your heart than if you had just stayed the same weight. It's about avoiding overeating, kind of getting caught up in this endless loop of overeating, feeling guilty about overeating, giving up, but then feeling bad and going back to restriction, and then overeating and feeling bad. It's like this endless loop. So intuitive eating helps to avoid that loop. And it's comprised of 10 principles that we're going to go over. So these principles are designed to increase your interoceptive awareness, that term that I used earlier. So number one, the first principle, first off, reject the diet culture and chronic dieting, because that's what intuitive eating is about. It's an anti-diet approach. So basically rejecting anything that made you feel like a failure. Also, a lot of times when people are dieting, they say, I'll start Monday, or I'll start on the first of the month. And then what happens right before that first day? They overeat, right? They're probably going to overindulge before that first day of the diet starts. So you want to avoid that. Number two is honor your hunger. So a lot of times we don't pay attention to hunger. And if you're overly hungry, that can lead to unsound decision-making skills. So if you are overly hungry, what do you think is going to be the first thing you're going to eat? Like the first thing you see, right? That's probably going to be what you're going to eat because you're so hungry. Yeah. And I do want to acknowledge that maybe there are people here today who are actively going through cancer treatment. And I do realize that poor appetite or decreased appetite is a very common symptom. And so I just want to let people know that maybe you don't feel hunger because of, decreased appetite from treatment. So this is a hunger and fullness scale. If you came to my table, you probably saw this. Did anyone take this handout? Okay, let me take a sip here. So this is from 1 to 10. So 1 being extremely hungry, dizzy, shaky, maybe low blood sugar. 10 being just uncomfortably full. We also call that Thanksgiving full. And then 5 is in between, neutral, comfortable, not hungry, or full. So ideally, you would start at a 3. A 3 is hungry, your stomach is growling, like very clear signs of hunger. And then you would stop at a 7. That means comfortably full, content, satisfied. So basically, if you start at a 1, when you're overly hungry, and you eat, your body's probably not going to realize you're full until you're about a 9. That's going to happen. So it's better to eat when you're comfortably hungry and stop when you're comfortably full. Does that resonate with anybody? Okay. So yeah, between a 3 and a 7 there. Number 3 is to make peace with food. I think this is the hardest part for a lot of people. Giving yourself permission to eat, because the more you tell yourself no, the more you're probably going to want to eat that food, right? That's just how our brains work. It's also being comfortable around foods because, like I said, restriction is actually going to increase your cravings. And this has been shown in the research. People who are chronic dieters, when they're in that dieting mode, they actually end up having more cravings. Number 4 is discover the satisfaction factor. So enjoying your meals so that you feel satisfied, you feel comfortable. Also, and just so you know, I do have this handout at my table and it has all 10 principles on the page. So you can always grab that. But if you're out to eat and you're in a social situation, you want to enjoy your meals, right? It's all about enjoyment. I think the Europeans are way better than Americans at that, enjoying their food, enjoying the experience. And learning to trust your body. A lot of people feel like, I just can't trust my body. So I want to remind you that children are actually really good at this. They're really good at identifying when they're hungry and when they're not hungry. And if you ever seen like a toddler eat, sometimes they take one bite and sometimes they eat everything. And that kind of drives us crazy, right? Because we're like, they're not eating enough. But really, they are so in tune with those senses. That's why they kind of eat like that. And as we get older, we lose that. We don't pay attention as much to those sensations. So just a quick story about my daughter. My younger daughter, we were on vacation and we were at the hotel and there was like chips and candy in the lobby and we were eating out, most of our meals. And so we got home and she was like, Mom, can you make me a salad? She just wanted something healthy because that whole weekend we had just been eating a lot of processed foods, right? And my other daughter is more open to a variety of foods. She's kind of experimenting more with different types of food. So I'm just trying to encourage her and trying to support her in that. Because that's what we want. We want to eat a variety of foods and be comfortable with a variety of foods. All right, number 5, feel your fullness. So this goes back to the hunger and fullness scale. And you can pause, literally pause halfway through your meal and ask yourself, am I full? And if you're not full, then you can keep eating. And if you are full, then maybe you put the rest away in the refrigerator for leftovers, or you ask for a to-go box. So you literally can check in with yourself and say, am I full? Number 6 is challenge the food police. So maybe there was somebody in your life who was the food police. Maybe it was parents. Maybe it was a coach. And so think to yourself, whose voice do I hear? Is there somebody's voice that is like the food police for me? So just think about that. I'm not going to have you say it out loud, but just think for a second. Number 7 is to cope with your emotions with kindness. So a lot of these principles have to do with like being kind to yourself. Emotional eating is very common. And so you can ask yourself, am I hungry? Or is it something else? Am I avoiding a feeling? Am I avoiding an emotion? And then I'm eating for that reason. And so if you do find you're eating for emotional reasons, identifying that, and then maybe going to do a journal, just some journaling, or maybe you call a friend, or maybe you go for a walk. So you kind of say, okay, I'm not hungry. I'm actually just eating because I'm avoiding something. And so then you kind of go and do something else. Number 8 is respect your body. So stop being overly critical. That kind of goes back to the whole, magazine cover, this kind of ideal body type. So it's more about being kind to yourself and then changing your inner dialogue. And number 9 is movement and feeling the difference. So you're most likely going to continue an exercise program if you enjoy it versus if you just really hate it, right? So move your body in a way you enjoy. And then over in the conference room, we actually have local resources available, especially around exercise programs. So if you haven't already, make sure you visit them. And number 10 is honor your health with gentle nutrition. So this is all about progress over perfection. So striving to, majority of the time, eat well, but it doesn't have to be perfect. And if you are getting away from the diet mentality and more into the intuitive eating mentality, it's going to ebb and flow because this is a process, right? And also changing your way of thinking is hard. So dieting tends to be very linear. There's an end goal. And intuitive eating is not. Intuitive eating is more like checking in with myself. How am I feeling? Am I hungry? Really using your own intuition. And then you want to focus on making small changes that are going to last. It's important to stay present, be aware of your thoughts and your inner sensations. When you listen to your hunger and your fullness, you're most likely going to eat what your body needs, the amount that your body needs, because we're not putting rules around, I can only eat this much. When you eat, start when you're hungry and stop when you're comfortably full. That's probably the amount of food that your body needed. And then also it's about having less anxiety around food. Like we talked about, giving yourself permission, because the more you say no, the more your body's going to want that. So it's about just being gentle and saying it's okay to have a little bit of this thing. And then you're probably going to have less anxiety around that food. So in the research, they've looked at people, like given people an intuitive eating questionnaire or an intuitive eating scale. And what they found is that people who score higher on intuitive eating have greater body satisfaction, greater life satisfaction, more optimism, increased self-esteem. They eat a wider variety of foods, and then they have greater motivation to exercise, especially when they're doing it for enjoyment. We're going to get into some real life situations now. Number 1, a person is restricting their eating for weight loss purposes. So let's say this is what they ate for breakfast and lunch. They had 2 egg whites, a small container of yogurt, and then a 1/4 cup of blueberries. And then at lunch, they had a 3-ounce plain chicken breast on top of a salad with some light salad dressing. So right off the bat, does that seem like it's enough? Probably not. So that's about 500 calories, right? From 2 meals. So maybe somebody could do this for a couple days, maybe a week. After a while, though, their cravings are probably going to start increasing. And then what happens? At dinner or after dinner, they might overeat because they didn't eat enough during the day. A lot of people are nodding your heads. I'm glad this resonates. So let's revise this. Let's look at this in a different way. Instead, a person thinks about whether or not they are hungry. They choose healthy and realistic options, and they eat for pleasure. So let's look at a different meal. At breakfast, they have 2 eggs, not just the whites. They make it into an omelet with some cheese, tomatoes, bell pepper, and then they have 1/2 cup of mixed fruit. So a variety of fruits. And then at lunch, they still have that grilled chicken, but this time it's on a sandwich. And they add onion, lettuce, tomato, and they have a small bag of baked chips. So now this is about 1,000 calories. And let's say somebody needs 1,500 calories in their day. That's about 500 at breakfast, 500 at lunch. And then by the end of the day, they're going to feel satisfied. They're going to go home and maybe eat about 500 calories at dinner because they don't feel like they were restricted during the day. Okay, real life situation number 2. A person does not eat dessert at a birthday party in order to be good. So this is a social situation. And I also want to point out this person wanted to have dessert, but didn't allow themselves to have it. Because sometimes you don't want dessert. Sometimes you really don't. You're like, I'm good. But if you do want dessert and you don't eat dessert, then you might go home and not feel satisfied and kind of looking for something else to fill that void. So maybe they start snacking. They have some crackers and cheese, maybe some baby carrots, but then they want something sweet, maybe a toaster pastry, and then some chips. So the calories in a small piece of cake or pie, that's like 250 to 350 calories. But if you ate all of those snacks, that's 550 calories. So you actually end up eating more, right? Because you're just like, and you might not even realize it. Maybe you're just looking for something to kind of fill that satisfaction. So you eat and eat and eat, and then it ends up being more than it would have been in the first place. So let's revise this one. Instead, a person has dessert because they want to enjoy it. They want to savor the flavors. So this is about avoiding guilt and shame and challenging the food police. Probably going to go home and feel satisfied without looking for some way to fill that void. Does that make sense? Okay. And number 3, now we're talking about exercise. A person is on the treadmill for 60 minutes just for the sole purpose of burning calories. 60 minutes is a long time when you're on the treadmill. So they might feel tired and worn out. They might feel resentful of other people who aren't at the gym doing this. They might overeat because they're like, well, tomorrow I'll just be back at the gym, so I'll just overeat now and burn it off later, right? So let's revise this one. Instead, a person engages in exercise they enjoy without feelings of guilt. They're probably going to feel more empowered, more fulfilled, have a better relationship with their body, and a better relationship with food. And also, it's important with exercise to change the narrative about why you're exercising. So this is personal for everyone. Maybe it's, I want to be able to move around and play with my grandkids. I want to lower my blood pressure or cholesterol. I want to lower my risk of dementia. I want to sleep better. I want to be stronger. These are all different ways you can think about exercise. And again, I want to acknowledge anyone here who's actively going through treatment, because there might be side effects that you're experiencing: nausea, constipation, diarrhea, taste changes, mouth sores, fatigue. These are all possible symptoms. And so you can still use these 10 principles and still be aware of your thoughts. Like, what am I thinking when I'm thinking about food? And then again, be non-judgmental. We talked about that in the beginning. So be non-judgmental about your thoughts, just be aware of them, and then figure out what's going to be the best thing for you to do that day, because you need to listen and honor your own body. And it is important. I talk to all of my patients about eating a good amount of protein, an appropriate amount for them. And on the days you feel good, make sure you're including those nutrient-dense foods. Okay, so let's focus. We're going to end this presentation focusing on that last principle, number 10, about honoring your health with gentle nutrition. So this is an example of nutrient-dense foods versus calorie-dense foods. Has anyone ever heard that term, nutrient-dense foods? Okay, good. So nutrient-dense foods are going to give you just what it says: more nutrients, more vitamins, more minerals, more antioxidants. There's more color. You can see these are more plant-based foods. And then the calorie-dense foods are going to give you calories without a lot of the nutrients that your body needs. So you can also see they're not as colorful, kind of more carbohydrate, unhealthy fat sources. But again, it's all about not striving for, I have to eat nutrient-dense foods 100% of the time. It's more about being cognizant of these differences, but then also listening to what your body is craving. And when you use nutrient-dense foods in your meals, you can add them to what you're already eating, and you want to make it fun and colorful. And I'm a big proponent of that, just making sure that you are adding to what you're already eating. You can add fruits, you can add vegetables, and also, like with the water, you can infuse your water to make it taste better. And just, I want to touch on the research about plant-based diets. So there was a study in 2022. It was a very big study. They looked at over 30 research articles, and these were the findings. People who had a high nut intake, this was associated with better survival for colorectal, breast, and prostate cancers. And people who ate more whole grains and fiber had a decreased risk of colorectal cancer. And there was another study in 2020, another big study that looked at 28 research articles. And this was showing that people who had a diet high in fruits and vegetables, it was associated with lower cancer mortality among head and neck cancers and people with ovarian cancer. So there are resources available because, again, if people are saying, well, how do I make my meals more balanced? And there are resources. Is anyone familiar with the My Plate graphic? So in 2010, the My Plate graphic replaced the old food pyramid. Does everybody remember the food pyramid? So this is the newer graphic. It's available on myplate.gov. So basically half your plate is fruits and vegetables. The other half is whole grains, including whole grains and protein, and then also dairy. And there's also the New American Plate. I have a handout at my table with the New American Plate description. So 1/3 of your plate is animal protein, and then 2/3 of the plate is plant-based foods. And I also have this handout. This is from the American Institute for Cancer Research. So they have the New American Plate graphic. These are their cancer prevention guidelines, but also these can be used during treatment as well. So I know the print is teeny tiny, but it's basically saying how nutrition can help you during treatment, how it can help your body thrive and heal and stay strong. And then also there's the question, what should I eat? So it's basically, again, going through 2/3 of your plate would be plant-based foods, 1/3 would be the animal protein, limiting red meat. So the recommendations for red meat, according to American Institute for Cancer Research, are 12 to 18 ounces per week, and not more than that. And then also eating little, if any, processed meats, limiting the amount of processed foods and added sugars, and then limiting sugar-sweetened drinks as well. So I want to highlight this. There's a little statement there at the bottom that says, work with your dietitian to tailor this and make it individualized for yourself, because everybody's different. And so we can work together to figure out what is going to be best for you. And this is a page out of our nutrition booklet that I give to patients in the Cancer Center. So again, the big question there is, what should I eat? What can I eat? And the guidelines are very similar there in terms of more plant foods and healthy fats and protein sources. And also just some information there about maybe there's a certain day when you just need to do what's best for you and you need to tailor this to your individual situation. And each of you should have received this healthy parfait recipe. This is in the bags. And then also I have lots of copies over at my table. And so this is a healthy parfait recipe. We've been talking about plant foods and healthy fats. So this includes a high protein Greek yogurt. And if you are lactose intolerant, you can always do a non-dairy yogurt. It includes honey, granola, which is a whole grain, nuts, and then mixed berries. So all of those foods that we were talking about, they're all included in the recipe. And the best part is each of you is going to get to make your own parfait. Our catering staff is going to set up a parfait bar out here where the breakfast was, I believe. So everybody can, before you leave today or as you continue to walk around the booths, you can make your own parfait and include all of these healthy ingredients. Are there questions?
Does fullness come from amount of food, or would a nutrition-rich diet be less filling than a protein or a carbohydrate-rich or calorie-rich diet?
Yeah, so fiber and protein can help you feel fuller longer. But fullness really is based on your own body. So like I said, halfway through the meal, you can put your fork down and just kind of check in with yourself and ask yourself if you're full or not. So certain foods will make you feel fuller, especially like over a longer period of time. But whether or not you're full is based on your own body cues.
How do you address the loss of appetite during treatment? Because
Yes.
some days I just don't even think about food at all, and I don't want to eat.
Yes. Yeah. And like I said, that's very common. So what you can do is maybe eat smaller amounts more often. So throughout the day. And sometimes if your appetite is poor, a big meal can feel overwhelming. So you don't want to necessarily do that, but smaller things and then throughout the day. So eating more often can be helpful. Also, if you aren't eating what you normally would eat, you can do nutritional drinks. So for example, Ensure, Boost, there's another brand called Orgain. There are lots of nutritional supplements available. And so you can drink those, especially if you don't have your normal appetite. Okay, so your spouse has an appetite, but you don't. Yeah, so there are a couple of things that can happen. If you have a poor appetite, and maybe a family member is encouraging you to eat, and it can almost become like annoying, like the person who doesn't feel hungry feels like, stop telling me to eat. I'm not, and so that's very real. That happens. So that's more of a give and take. And then also, if your spouse or your family member is eating more and then you're not eating as much, there's a disconnect there. But social eating actually can help increase appetite. So if you're eating with other people, if you're eating in a pleasant environment, like sitting outdoors, that can sometimes help with appetite too, because everyone is eating and enjoying the experience.
You had that, I think, 2-egg omelet. Is that enough protein?
Yeah, good question. So 2 eggs is going to give you about 14 grams of protein. What else did I have on there? It was the 2-egg omelet and the fruit. So if you need more protein than that, you can always add eggs. Yeah, so you can add another egg. You can add a side of Greek yogurt. So there are other things that you can add.
And how about healthy fats? Like, would that be included in that? I didn't see.
Yeah, you can definitely add avocado. Avocado. You can always add a healthy fat. I have a handout at my table about healthy fats. I'm always encouraging my patients to eat those.
Thank you.
Yeah.
Artificial sweeteners like stevia, is that like a good substitute? I mean,
yeah, you can use stevia. What are the others? There's monk fruit. Yeah, so there are other artificial sweeteners. I'm not a big fan of like Sweet and Low and Equal and things like that, but stevia would be a fine substitute. Yeah.
So people had hormonal related cancer. For them, do you recommend a dairy product or estrogen that is found in the fruit? What do you think about that?
You don't have to highly restrict your diet based on the estrogen status. One thing I do get a lot of questions about is soy. So a lot of patients ask me, is it safe to eat soy, especially after a breast cancer diagnosis? And it is still safe to eat soy as long as they're whole soy foods. So things like edamame and tofu, tempeh. You don't want to do a lot of processed soy foods like in powders or protein bars. And again, I think having like a recommended amount of dairy is fine. You don't have to restrict, dairy. And there are some foods that are actually beneficial in terms of breast cancer. So things like flaxseed. So you can incorporate healthy foods like that, the healthy fats into your diet.
Yeah, some say like avoid flaxseed, chia seed that have estrogen in it. So phytoestrogen. So,
and I think you would have to eat a lot of those seeds to really have any impact on hormones. If you even see like a teaspoon of flaxseed, it's a pretty good amount. So I think the recommendation is no more than 1 to 2 tablespoons, which I don't think most people are eating that many flax seeds and chia seed.
And for dairy, how much? Like yogurt or milk or?
I think based on the dietary guidelines, it's 3 servings of dairy per day. So that might be like half a cup of fruit, a cup of milk. So, like some cheese. So as long as you're not having, 7, 8 servings of dairy per day.
All right. Thank you.
Fine.
I was wondering, although it's not dieting, what do you think of intermittent fasting?
Intermittent fasting can be beneficial. There's more and more research about intermittent fasting. And even the research has shown that 12 hours of fasting is beneficial. So it doesn't have to be like 20 hours of fasting, even 12 hours, 14 hours, they've shown can be beneficial on your blood sugar, on weight. So it doesn't have to be like extreme.
What are the recommended diet to increase the platelet count?
There are some foods that can help with platelets, leafy green vegetables. I know papaya can be helpful, but I don't know like how, I can't say it would raise your platelets this amount. So I think it can be helpful to include those healthy foods to maybe support your platelets. But it's hard to say like how much it would actually help. So it's good to talk with your doctor about what your platelet counts are.
So when you're talking about the healthy foods, are you talking like specifically organic versus non-organic?
So if you have the means of getting organic foods, then absolutely organic can be beneficial. But my take is if it's too expensive and that's hindering you from buying produce, just go ahead and get the conventional version, because we still want you to eat fruits and vegetables either way. So it's not that clear cut.
Thank you very much.
Let me just say one more thing about that. There's the Clean 15 and the Dirty Dozen. Has anyone ever heard of that? That can kind of guide you in terms of which foods you should try to buy organic versus conventional. So the Clean 15 and then the Dirty Dozen. So the Dirty Dozen are typically the foods that are most used with pesticides. So you can easily find that on the internet.
I was wondering how to balance the intuition and discipline, or is discipline coming to the scene at all?
So it's more about changing the mindset of, so again, if you're restricting food, your body's more likely going to want that food. So it's more about being kind to yourself, using your own intuition, and then less about discipline and willpower, because those tend to not be as lasting, those effects, versus using your own intuition is probably going to last longer. There have been some claims about eating artificial sugars actually led to more cravings, or it led to eating more in the long run. So I think that's different for every person. That might be the case for some people. If you wanted to avoid artificial sugars, what you could do is, if you're using real sugar, just cut that amount in half. So say you're using it in a recipe, just cut that amount in half and still use the real sugar, but you're not getting as much. So that's another option.
It's a beneficiary to avoid sugar at all, because some of my family members, they don't eat anything sweet at all. Mm-hmm. But I really like sweet, so.
Yeah. So sweets can still fit in. And again, it's more about following your cravings. So more about what sounds good to me. If there's something that's sweet, go ahead and have some, so that you're not looking to fill that with something else and end up overeating. So it's fine to have a small amount of whatever it is that you're craving, even if there is sugar in it. And then again, it's more about progress over perfection, so kind of striving majority of the time to have those healthy foods. All right. Well, thank you so much. Thank you for staying on and listening. Please visit my table if you have any other questions.